So today's topic is on the chemical control of respiration. The day before yesterday, we spoke about the neural control of respiration. Kiran, the screen call and danger. This is daily.
It's
Thank you.
track Jason.
So regarding the regulation of respiration, breathing is controlled by the central neuronal network to meet the metabolic demands of the body. So there is alteration in the breathing depending upon the situation, whether you are sleeping or whether you are emotional or whether you are subject to exercise or some pathological conditions, as the case may be, depending upon the situation. So here it is regulated by one particular mechanism, that is the neural mechanism. The other one is the chemical regulation. So under quiet respiratory conditions, as we discussed in the previous topic, this slide is not up to the mark. So you have the inspiration, wherein there is enlargement of the thoracic cage in three-dimensional way, where the sternum is moved forwards here, and then the diaphragm moves downwards and sideways. So the three-dimensional picture size is increased, and subsequently the air gushes into the respiratory tract and then expands the lungs. That is the inspiration or the ventilation, where air is coming in contact with the alveoli. Whereas the expiration is mostly a passive phenomenon, wherein the elastic recoil of the lungs are sufficient enough to bring about this. So normally we speak about the internal intercostal muscles for inspiration, mainly diaphragm, and the scalene muscles in case of listening. And expiration, the external intercostal muscles. And basically it is here you must remember that there is an oscillatory model, something like the pendulum. So when the pendulum moves toward the inspiration takes place, and the pendulum moves toward the expiration takes place. So this is the same thing, which another picture depicting the external intercostal muscles and the diaphragm contracts in the chest wall as the three-dimensional expansion, and that results in the gushing of the air. Normally under quiet respiratory conditions, about 500 ml of air will enter into the lungs. And then in expiration, 500 ml comes out. So you must be knowing about the lung volumes and capacities, wherein amongst this tidal volume, 150 ml remains in the respiratory tract, that is trachea, bronchi, up till the alveoli. And this is called the anatomical dead space, the structural anatomy, wherein the air from 500 ml of tidal volume, which does not participate or contribute in the actual process of gaseous exchange. So that is called the anatomical dead space. Here you must also remember another term that is called the physiological dead space. So what additional things does physiological dead space mean is the alveoli which are not aerating, the alveoli which are not aerating in the sense not having the pulmonary circulation there, or the excess amount of air that reaches the alveoli over and above the capability of the alveoli. So these two additional factors contribute to the physiological dead space. That is, Air is more air is reaching the alveoli, and more air is reaching an alveoli which is not perfused or which is not having the circulation. That's the reason it's called the physiological dead space. During quiet respiratory conditions, there is elastic recoil, and then the sternum moves backwards, and then the thoracic cage relaxes and diaphragm moves up. All these things occur during the expiration. Here, the sequence of events you must have learned in the mechanics of respiration, wherein the rib cage descends due to elastic recoil. There are all the steps. Thoracic cavity volume decreases, changes in the anterior posterior diameter, and then the sternum are depressed, that is during the expiration. The sternum is depressed, external intercostal muscles relax, diaphragm moves superiorly. So this is what happens during the expiration. We should remember inspiration. Normally is the tidal volume. If it is more than 100 ml, 1000 ml. So that is the normal quiet respiratory conditions is 1000 ml, 500 ml. So suppose you breathe in, you take in more amount of air, for example, in severe exercise or overstretching your lungs. So that overstretching of the lungs result in expansion of your lungs. And that specifically stimulates some stretch receptors which are there in the thoracic cage, thoracic wall in the lungs. That initiates what is called Hering-Brewer's inhalation reflex or Hering-Brewer's reflex, inhalation reflex. So that stimulation of the receptors will result in sending nerve impulses through the vagal efferents, and then that inhibits the inspiratory center, namely the dorsal respiratory group, and subsequently it results in the a decrease in the inspiration. In other words, what happens is when more amount of air is taken in, it results in the stretch of the lungs, and that stretch of the lungs will stimulate the receptors, and those receptors will send nerve impulses. These nerve impulses will cause inhibition of the dorsal respiratory group. So basically, all the pathways will move in this direction. This is the pons and this is the medulla. So normally the apnostic center will be stimulating the dorsal respiratory group, and this is the pacemaker, something like the SCN node in the heart. This is pre-Botzinger complex, and this is stimulated, and that results in the inspiratory act. And similarly, the ventral respiratory group will result in the stimulation of the motor neurons. And you must remember, these apnostic and hemotaxic centers are situated in the pons. And in the medulla, you find the dorsal respiratory group and the ventral respiratory group. Dorsal respiratory group for inspiration, and then the ventral respiratory group for expiration. Here, this is the oscillatory module, and this is the pacemaker of this particular thing. And the stretch receptors, which I mentioned, are the mechanoreceptors. So when CNS topics are dealt with, so there will be a lot of receptors in different locations. Some are mechanoreceptors, some are proprioceptors, some are photoreceptors. All these receptors, there are a lot of classifications which you will learn later. Respiratory muscles are stimulated, and that gives a feedback to the ventral respiratory group. So this is one of the flow diagrams which you can remember. In short, what happens is you must link the brain area with that of the thoracic cage area. What normally happens in the chemical control of respiration, the details I'm just going to the later part. The brain, you have the brain circulation to the brain. You have the cerebrospinal fluid, and you have what is called the blood-brain barrier. And the chemical receptors are there. One is the peripheral chemoreceptors, the other one is central chemoreceptors. Here, the substance, namely the carbon dioxide, is capable of entering into the blood CSF barrier or into the cerebrospinal fluid because of the smaller molecules and because it is soluble in water and because of it is permeable. This carbon dioxide molecules will be entering into the cerebrospinal fluid. But actual receptors, namely the central chemoreceptors, are stimulated by the hydrogen ion concentration, the details of which I will come later. So normally the carbon dioxide molecules will be entering into the cerebrospinal fluid. And you have the in the lungs and alveoli, the carbon dioxide concentration in the blood which is bathing the alveoli is more. So carbon dioxide comes out into the tracheobronchial tree and then it is exhaled in the normal process. So what you should, at least you remember at this point of time, the carbon dioxide is permeable or carbon dioxide enters through the cerebrospinal fluid, blood-brain barrier. So under quiet respiratory conditions, the blood, this is the blood flow and this is the alveoli. So as you are breathing in the tidal volume, 350 ml of the air which you are breathing in is coming in contact with the alveoli, wherein the oxygen tension is much higher. So oxygen enters into the blood and it is tagged on to the hemoglobin molecules. Whereas the carbon dioxide tension is more in the venous blood. So carbon dioxide enters into the alveoli in the process of exhalation will be breathed out and then you have the fresh amount of air coming in. So this is another picture showing the carbon dioxide is coming into the alveolus and oxygen is going in and tagged on to the red blood corpuscles, to the hemoglobin molecule. So here you must remember a single red blood corpuscle will contain enormous number of hemoglobin molecules, not a single hemoglobin molecule. This point you must remember. So this is the trachea and these are the alveoli which you are talking about, respiratory membrane. And you have two different types of cells, namely the type 1 cell and type 2 cell. Type 2 cells are the type 2 pneumocytes are also called the Clara cells. They elaborate surfactant, that is dipalmityl phosphatidyl choline. So oxygenated blood is transported by the branches of the pulmonary vein to the heart. And deoxygenated blood is transported by the branches of the pulmonary artery to the lungs where they get oxygenated. So the same picture we can practice. So this is the carbon dioxide and then oxygen exchange that is taking place here. The carbon dioxide, that is deoxyhemoglobin, releases the carbon dioxide. And these are the type 2 pneumocytes and type 1 pneumocytes here. The oxygen is tagged on to the hemoglobin molecules in the red blood corpuscle. You should remember that a red blood corpuscle will be traveling 3 alveoli in a space of 3/4 of a second for oxygenation. It traverses through 3 different alveoli to get oxygenated. So just a word so that you remember these things. It's a revision for you. So under normal quiet respiratory conditions, 500 ml of air is breathed in and breathed out of the lungs. So this particular thing is called the tidal volume. Over and above that, you are still capable of taking in more air. That is called the inspiratory reserve volume. So you still have the capacity to breathe in more amount of air into the lungs. That is called the inspiratory reserve volume. Generally, when you are talking about the lungs and capacities, when you take two volumes into consideration, it is called capacity. When you take two volumes into consideration, it is called capacity. When you consider the tidal volume and the inspiratory reserve volume together, it is called inspiratory capacity. So in the examination, when any one of them is asked, you have to mention that inspiratory reserve volume is different and inspiratory capacity is different. Similarly, you still, after quiet respiratory conditions, you still have capacity to breathe out some more amount of air. That is called the expiratory reserve volume. SC, expiratory reserve volume. When you consider tidal volume and expiratory reserve volume together, it is called expiratory capacity, capacity for expiration. Still some amount of air will remain in the alveoli. That is called the residual volume, which is roughly about 1,000 ml of air. So you have the residual volume, and after quiet respiratory condition, after quiet expiration, the expiratory reserve volume and the residual volume together is called functional residual capacity. Functional residual capacity. This diagram is an important diagram which is must for every student, not only from here, from practical point of view, where you'll be doing the vital capacity experiments in an instrument called the spirometer in the practicals, where you are going to do this exercise. So there is one more thing called the vital capacity. Vital capacity is defined as the maximal amount of air which you can breathe out after maximal inspiration. Note down, vital capacity is defined as the maximal amount of air which you can breathe out after maximal inspiration. So after inspiring maximally to your capacity, the air, if we can blow out, is called the vital capacity. Let us say you breathe in maximally, and then from this point of thing, you breathe out maximally. This is the vital capacity. So this roughly gives you about the underlying capacity of your lungs. At the same time, this roughly gives you an idea about the underlying pathology existing in the lungs. So this is very important for you at this point of time. So this tidal volume and other things will be reduced whenever there is compromisation of the functioning of the lung. Note down these values. So tidal volume is 0.5 liters and inspiratory reserve volume is 3.3 in males and 1.9 liters in females. 3.3 liters in males, it is slightly more. So these are the Western standards. Probably Indian standards, it may be much lower than this. And in females, it is 1.9 liters. Expiratory reserve volume in males is about 1 liter, whereas in females, it is 0.7 liters. And residual volume is roughly same in both males and females, is 1.2 in males and 1.1 in females. And total lung capacity is roughly 6 liters in males and 4.2 liters in females. So when we are speaking about the tidal volume and inspiratory volume, it is the inspiratory capacity. When you are speaking about the tidal volume and inspiratory reserve volume, it is called the inspiratory capacity. When you are talking about the expiratory reserve volume, and the residual volume, it is functional residual capacity. And when you are talking about the inspiratory reserve volume, tidal volume, and expiratory reserve volume, it is called the vital capacity, which we have defined as the maximal amount of air which you can breathe out after maximal inspiration. So, in what conditions it will be useful is the obstructive lung disease and the restrictive lung disease. At this point of time, I am not going to elaborate further here. Just remember, obstructive lung disease means there is an obstruction to the flow of the air, whereas the restrictive lung disease means there is a restriction to the aeration of the air. So these terminologies you can just remember at this point of time. Obstructive lung disease and restrictive lung disease. So, for example, obstructive lung disease is the bronchial asthma or allergic bronchitis, wherein there is narrowing of the bronchi and bronchioles. Whereas the restrictive lung disease is there is damage to the lungs, and then there is fibrosis or there is a cavity which is existing in the lungs. So these two things will be differentiated by another test, which is called the timed vital capacity. Note down this one. If the vital capacity is recorded on the thymograph, the volume of air expelled can be timed. Normally, 75% to 80% of the vital capacity should be expired in the first second. That is FEV1. This is very important term, FEV1. Note down. Generally, in the examination, they just mention it, FEV1, and you have to mention about this timed vital capacity. This measurement is much more sensitive index of the severity, but also does not allow for the differentiation of the various causes of obstruction. So this gives a roughly an idea about the obstructive lung disease or the restrictive lung disease. So suppose if this is obstructive, the FEV1 may fall from 80, it will be coming to 60 or 50. Whereas the timed vital capacity in the restrictive lung disease, remains constant, namely the 75 to 80%. From among the existing lung capacity, the individual is able to breathe out about 80% from the available lung, which he is having. So that is the way in which you differentiate obstructive lung disease from the restrictive lung disease. So this is out of context here, but I just want to show you. Whenever you have time, you try to purchase one BP apparatus and practice this particular experiment wherein you can measure the blood pressure of the members of your family, relatives, etc. So that you get familiarized with the process of practical thing which you will be doing. So in the practicals, you will also be doing another experiment on the blood pressure. So the conditions in which you the methods in which you will be measuring the blood pressure, and conditions in which you with the blood pressure is increased or decreased, and what are the factors which alter all these things you will be learning. So it is it doesn't cost much, about 500 to 600 rupees, the BP apparatus you can buy, and one stethoscope, so that you can keep practicing the details when you do the practicals in our lab. So here what happens is there are different methods, wherein the palpatory method and then the auscultatory method. So you'll be finding the sounds coming out from the systolic pressure to the diastolic pressure, and there'll be some gradations of the sounds. These are called the Korotkov sounds, which you will be learning when you come to the practicals. Just a suggestion, not necessary that you should follow this. And we are talking about the chemical control of respiration. So the chemical control, I think you remember, you have the chemoreceptors. The chemoreceptors are present in the arch of the aorta and also in the bifurcation of the carotid artery. So common carotid bifurcation where carotid bodies are present. So here, the structures which are involved, the central chemoreceptors, the peripheral chemoreceptors, and then the centers in the brain, namely the pons and the medulla, which I refer to as the agnostic center and pneumotaxic center. Day before yesterday, I was talking to you about the nucleus tractus solitarius in elaborate, so that you recollect now. The chemical control of respiration. The main function of the respiration is to maintain proper concentration of oxygen, carbon dioxide, and hydrogen ion concentration. So it revolves around these three molecules, oxygen, carbon dioxide, and hydrogen ion. So if you have a control on all these three, you can just master this. Increased or excess of carbon dioxide and hydrogen ions in the blood act on the respiratory center in the brain. Here, I want to tell you that carbon dioxide will be acting directly on the peripheral chemoreceptors, or oxygen lack will be acting on the peripheral chemoreceptors, but hydrogen ions are mainly responsible for the stimulation of the central chemoreceptors. So here you must remember that predominantly 85% of the chemical control of respiration is through the central chemoreceptors. Only 15% of the chemical control of respiration is via the peripheral chemoreceptors. This point you must remember. So it is the hydrogen ion which is going to stimulate the central chemoreceptors, which are situated on the dorsal surface of the medulla. Oxygen does not have any direct effect on the brain. Oxygen does not have any direct effect on the brain. The brain does not store any energy. The brain does not store ATP and glucose in the brain. So there got to be a continuous supply of blood to the brain. So the continuous supply of blood to the brain is necessary for the normal functioning of the brain. Brain directly uses this, and brain predominantly uses the greater amount of energy released by the body. Suppose if there is deficiency or if there is obstruction to the flow of blood to the brain, even for a period of 4 minutes, it will result in irreversible brain damage. So that irreversible brain damage will make the individual vegetate in the sense. So brain does not function further any time. So there should be a constant supply of blood to the brain. So whenever there is any patient who is having any injury, put them in flat position so that the brain receives adequate amount of blood supply. Oxygen acts mainly on the peripheral chemoreceptors and carotid and aortic bodies. Oxygen will be acting mainly on the peripheral chemoreceptors, which are present in the carotid and aortic bodies, which in turn transmit appropriate signals to the respiratory centers. So where are chemical chemoreceptors situated? They are situated in the deeper part of the medulla oblongata. Deeper part of the medulla oblongata, close to the dorsal group of neurons. So this point you remember, close to the dorsal group of neurons. This area is known as chemosensitive area, and the neurons are called chemoreceptors. So central chemoreceptors, which are there on the medulla oblongata, are sensitive to the changes in the blood chemistry, mainly the hydrogen ion concentration. So carbon dioxide enters into the cerebrospinal fluid through the blood-brain barrier. And this carbon dioxide, which is entering into the cerebrospinal fluid, combines with water, H2O molecules, to form what is called the carbonic acid. The carbonic acid immediately dissociates to form hydrogen ions and bicarbonate ions. So the bicarbonate ions move out into the blood circulation, whereas the hydrogen ions which are remaining there in the cerebrospinal fluid will be stimulating the central chemoreceptors in the medulla oblongata at the chemosensitive area and the chemoreceptor, the central chemoreceptors. So what happens is there is change in the hydrogen ion concentration of the cerebrospinal fluid. So yesterday I was telling you about the cerebrospinal fluid flow. That is 2 lateral ventricles and then goes to the 3rd ventricle. From there it enters into the 4th ventricle. As it is coming out from the lateral ventricles and then 3rd ventricle through the fenestra, it comes out, and then as it is bathing these medulla oblongata, it is moving over the receptor, the central receptor, and stimulate the central chemoreceptors, thereby resulting in initiation of the nerve impulse which goes to the chemosensitive area. Chemoreceptors respond to the changes in the constituents of the blood, namely, it results in hypoxia, means less of oxygen, hypercapnia, means increase in the carbon dioxide levels, and increased hydrogen ion concentration. These are the 3 things which mainly stimulate the chemoreceptors. So you have the carotid bodies which send signals to the central chemoreceptor area. And you have the aortic bodies which send signals to the chemosensitive area. That results in what is called the alteration or modification of the respirations. Or in other words, the respiratory activity is modified based on the input of the central chemoreceptors and peripheral chemoreceptors. Here it is the carotid body, and here it is the aortic bodies, carotid body and the aortic bodies. And the carotid body, the information is carried by the glossopharyngeal nerve. And from the aortic body, the information is carried by the vagus nerve. Yesterday, day before yesterday, when I'm talking about the nucleus tractus solitarius, wherein the tongue, the chemical sensations which are carried from the anterior 2/3 of the tongue and posterior 1/3 of the tongue are carried by the glossopharyngeal nerve, anterior 2/3 by the glossopharyngeal and posterior 1/3 by the vagus nerve, terminate in nucleus tractus solitarius in the medulla oblongata. And this medulla oblongata, the dorsal respiratory group, is part and parcel of the nucleus tractus solitarius. When we are discussing these things in a separate note, we call this as dorsal respiratory group. But in fact, they are embedded in the nucleus tractus solitarius. Hence, I spoke about that thing yesterday. And what is fundamentally the structure of the carotid bodies and the aortic body? These are chemosensitive bodies in the carotid bodies and aortic bodies, which constantly bathe with the blood and the cerebrospinal fluid, which are sensitive. So this is just a type glomus cell, the glomus cell, and you have the supporting cells, this carotid body and aortic bodies. You have the glomus cell, that is chemosensitive cell, and you have the supporting cells to form the carotid body and aortic body. They have the unmyelinated nerve endings here, and then which are closely in contact with the glomus cell. And this glomus cell, then it becomes myelinated, and then this myelinated one from this carotid body, then it goes up and then it innervates the chemosensitive area in the brain. And from this also the chemosensitive area cells, the information from the glomus cells, the carotid and body and aortic body, will be carried by the unmyelinated nerve fibers and then goes up. So based on the units, the weight of the chemoreceptors, it receives enormous amount of blood supply. It receives enormous amount of blood supply when compared to any other part in the body. Hence, it tastes the blood. It tastes the blood at every moment and sends signals to the brain to alter the respiration based on the concentration of carbon dioxide, the hydrogen ions, and oxygen. And these are the unmyelinated nerve fibers which carry the information. This diagram you must practice. And then subsequently, what happens is that releases a neurotransmitter whenever low oxygen. This is the further diagram of the release of the neurotransmitter from the glomus cell. So the low oxygen results in the fluxes of ions, and this fluxes of ions results in the closure of the potassium channels, and then the cell depolarizes, and then the depolarization of the cell results in excitation secretion coupling. Excitation secretion coupling. In the sense, you have this diagram you practice. Potassium channels close, the cell depolarizes, and then voltage gated calcium channels open, and calcium entry also happens, and the neurotransmitters which are there in the glomus cells are released, and they are released and by a process which is called exocytosis, and the neurotransmitter, namely the dopamine, are released, and dopamine acts on the post-junctional cell, that is the nerve terminal of the unmyelinated nerve terminal of the glossopharyngeal or the vagus nerve, and then it initiates the action potential, the same thing which I mentioned yesterday. So that action potential is propagated and then goes up and terminates in the higher centers in the chemosensitive area. This is the another flow diagram which we skip. And this is the glomus cell again, and then you have at the bifurcation you have the carotid body, and you have blood supply. The number of sinusoids are there, and then this is the nerve contact with these things, and then they release. And here you have the aortic bodies, and here it is the carotid bodies. The ultimate goal of respiration is to maintain proper concentrations of the oxygen, carbon dioxide, and hydrogen ions in the tissues. So the main purpose of respiration, together with the kidney, is maintenance of the constancy of the internal environment. So maintenance of the constancy of the internal environment is required for the homeostasis. So you should be internal environment should be constant for effectively functioning of individual cells. So this is brought about mainly by the respiratory system and also by the genitourinary system, that is renal system. Excess of carbon dioxide and hydrogen ions in the blood mainly act on the respiratory center itself. Oxygen does not have any significant direct effect on the brain. Instead, it acts almost entirely on the peripheral chemoreceptors in the carotid and aortic body. This point you remember. Oxygen, peripheral chemoreceptors. Hydrogen ions, central chemoreceptors. These receptors transmit appropriate nerve signals to the respiratory center. Based on the requirement, the oxygen level is brought back, the carbon dioxide level is brought back, the hydrogen ion levels are brought back by the maintenance of the acid-base balance in the system, to maintain the constancy of the internal environment for the effective functioning of the individual cells. This is not up to the mark. So as I said, these are the peripheral chemoreceptors located in the carotid body and aortic body. So these glossopharyngeal and the vagus nerve will come and innervate the dorsal respiratory group. And this dorsal respiratory group is very close to the chemosensitive area, that is nucleus tractus solitary, which tastes the chemical sensations in the body, that is the taste and smell and all these things will be doing and terminating there. So this is about the peripheral chemoreceptors which we are talking. And this is about the central chemoreceptors, that is the chemosensitive area here, respiratory area. So carbon dioxide combines with water, bicarbonate ions are formed, they dissociate, carbonic acid is formed, they dissociate, and bicarbonate ions are formed, negatively charged, and this positively charged hydrogen ions will combine, will be within the cerebrospinal fluid. As the cerebrospinal fluid is coming out from the apertures of the third ventricle and fourth ventricle, they overflow over the parts of the brain. Besides nourishment and supply of oxygen, they also give the changes in the hydrogen ion concentration, which stimulate the respiratory center and send appropriate signals to the dorsal respiratory group to alter the respirations. Another picture will show you these things. And this is what I'm trying to tell you about the flow of blood to the carotid body. Carotid body weighs about 2 milligrams, just 2 milligrams. So when compared to the other thing, the blood flow to the carotid body is 2000 ml. Suppose if it is 100 grams of the carotid body, it receives 2000 ml per minute. When compared to the brain, which is only about 54 ml. When compared to the kidney, it is 420 ml. When compared to the heart, it is 84 ml. So this receives enormous amount of blood, or the entire amount of blood is being supplied to the carotid body and aortic bodies, or the chemoreceptors, which just weighs about 2 milligrams. Another picture. So the oxygen deficiency, the glomal cells, and the afferent neurotransmitters. So practice the diagram so that whenever any question is asked in the examination, try to reproduce the relevant diagram concerned with that. So it will carry good impression. If you can practice with the sketch pens, it is much more advantageous to you. Blood vessel, oxygen, and then fiber. There is modification. Glomal cells. Glomal cell is nothing but the chemosensitive receptor cell. Not up to the mark. So this is the location of the carotid bodies. So the right carotid artery, common carotid artery, and left common carotid artery. These diagrams also you must practice. Aortic bodies here. Another variant of this. So in short, with the changes which are happening in the chemistry of the blood chemistry, and namely the oxygen deficiency, carbon dioxide excess, or increase in hydrogen ion concentration, it goes from the peripheral receptors and central chemoreceptors being stimulated. And subsequently, it will be stimulating the respiratory center, namely the inspiratory center. So inspiratory center in turn, depending upon if the carbon dioxide is in excess, inspiratory center is stimulated so that it washes out more of carbon dioxide from the alveoli to the exterior. So that is how the inspiratory act, it increases the rate and depth of respiration, wherein the rate of disposal of carbon dioxide increases. So this is about the heart rate and all that. I'll skip this. Central chemoreceptors are located, as I said, I think I have told you about this. Again, the mode of action of the central chemoreceptors. So this you can concentrate. Inspiratory center, namely the dorsal respiratory, how it is influenced. So normally, apnostic center will be, down this flow diagram. Apnostic center, as I said, these are the afferent impulses and this is the efferent impulse. Apnostic center will be stimulating the inspiratory center, namely the dorsal respiratory group. And this is in turn initiated by this pacemaker. And this will be tonically inhibited by the pneumotaxic center. The inspiratory center is tonically reduced by the inspiratory center. Inspiration and expiration together is an oscillatory model where one is stimulated, other is inhibited. When the expiration is stimulated, inspiration is inhibited. And this in turn is through the phrenic nerve. The phrenic nerve from this, the corticospinal tracts, which via the phrenic nerve will be innervating the diaphragm, and diaphragm contracts and pushes the viscera down. The peripheral chemoreceptors sensitive to the oxygen, carbon dioxide, and hydrogen ion will be stimulated. The central chemoreceptors may predominantly will be resulting in the stimulation through the hydrogen ions. When the lung is stretched because of deep inspiration, let us say we're talking about 1000 ml of air, that is under quite strenuous conditions. When you breathe in more, the stretch receptors are stimulated. That results in the initiation of the impulses from the stretch receptors, and that inhibits the inspiratory center. Similarly, you have the receptors from the proprioceptive receptors from the joints, which also will be stimulating the inspiratory center. For example, you are doing severe exercise and then running. So from the joint, you find the receptor. Those receptors are stimulating the inspiratory center. I'm trying to restrict to time allotted so that you don't leave in between. So the central chemoreceptors, actually the receptors are located here, where you have the termination of the where you have the glossopharyngeal and vagus nerve originating from the medulla. So this area, by two methods. One thing is, it is very close to the area which is getting stimulated. Central chemoreceptors are specialized area in the brainstem. As I said, brainstem is medulla and pons, and diencephalon is thalamus and hypothalamus, and over which you find the cortex. It is specialized area in the brainstem situated in the ventromedial aspect of the medulla. Note down this term. Ventromedial aspect of the medulla. Ventromedial aspect of the medulla, near the origin of the 9th and the 10th cranial nerves. These words are very important. Ventromedial aspect of the medulla, near the origin of the 9th and 10th cranial nerves. It is separate area from the respiratory center, but connected to the respiratory centers. Central chemoreceptors are not stimulated by hypoxia. As I said, not stimulated by hypoxia. They are stimulated only by the changes in the hydrogen ion concentration, which is formed in the cerebrospinal fluid. Carbon dioxide from the blood cannot pass the blood-brain barrier easily. Therefore, carbon dioxide does not influence the activity of these receptors directly, but do so by producing hydrogen ions. But they enter into the blood through the blood circulation, through the cerebrospinal fluid blood-brain barrier, combines with water and forms carbonic acid, which dissociate and releases the hydrogen ions. So this is the area which is sensitive, lying just beneath the ventral surface of the medulla. So pneumotaxic center, apnostic center, and dorsal respiratory group. Another way picture of the central chemoreceptors. Referring to the metabolic changes, and then carbon dioxide is formed. Just concentrate a bit here. Metabolic changes are happening, and due to metabolism, carbon dioxide is formed. Carbon dioxide will relax the smooth muscle and the brain tissue, and then enters through the blood-brain barrier. Enters through the blood-brain barrier. Enters from the tissues. It is coming to the blood-brain barrier, and carbon dioxide will be entering in carbonic acid that is formed in the arterial blood. And then this slowly permeates in the cerebrospinal fluid and slowly permeates and then stimulate the central chemoreceptors. The carbon dioxide sometimes directly enters to some extent very slowly. And this bicarbonate ion slowly passes into the CSF. The carbon dioxide enters into the CSF. And then hydrogen ions that are formed because of the dissociation here will stimulate the central chemoreceptors. So carbon dioxide to a lesser extent will be stimulated. Predominantly it is stimulated by the hydrogen ions. And you have the blood-brain barrier. In short, the carbon dioxide that is formed passes through the blood-brain barrier into the CSF. Dissociation, hydrogen ions stimulating the chemoreceptors as it is flowing over the ventral surface of the medulla ventral respiration volumes and capacities, which I have dealt before. The same. So sometimes the breathing pattern will be abnormal. So the pattern of breathing will be abnormal in cases of heart failure, the strokes, hyponatremia, traumatic brain injuries, sleep at high altitudes, toxic metabolic encephalopathy, carbon monoxide poisoning, syncope and coma, and morphine administration. All these things are abnormal breathings. Normally, if you see any movie or in the hospital, the different types of patients will be breathing differently. So that is mainly because of different underlying pathologies existing, whether it is heart involvement, whether it is changes in the blood chemistry or injury to the brain, or the tumors in the brain, or because of toxic conditions or carbon monoxide poisoning. All these things will be altering the breathing pattern. So in spite of your chemical control and peripheral control and neural control, these things do happen in abnormal conditions. One thing that is another abnormal pattern of respiration is chain strokes breathing. Note down this or highlight in your textbook. Chain strokes respiration is an abnormal pattern of the breathing characterized by progressively deeper and sometimes faster breathing, followed by a gradual decrease in respiration. So what happens is the breathing slowly rises up. There is element of breathing and then slowly rises up and then suddenly comes to a stage of apnea. So in short, what happens is there is a crescendo rise, and again there is a decrescendo rise, and then followed by the period of absence of breathing, that is called the apnea. Apnea, as I told, the transient cessation of respiration. So the breathing pattern in chain stroke breathing is there is enhancement of the breathing and increase in the frequency, and followed by slowly decrease in the frequency. Then there is sudden absence of breathing. That particular pattern is called the chain strokes breathing. You find this diagram in your textbooks. The pattern repeats with each cycle, usually taking about 30 seconds. And this is a period of hyperventilation followed by a period of apnea. Hyperapnea with a crescendo oblique decrescendo pattern and is associated with changes in the partial pressures of oxygen. What happens in the chemistry here is as you are breathing more and more, the respirations goes up. It is breathing out more carbon dioxide. When the carbon dioxide is washed out from the individual alveoli, the blood carbon dioxide level falls. When the blood carbon dioxide level falls, there is no longer any stimulation to the respiratory center. So the respiration stops. So that cessation of respiration, which is called the apnea, the transient cessation of respiration, absence of the respiration will result in the accumulation of the carbon dioxide again. That accumulation of the carbon dioxide again stimulate the respiratory center and another cycle of crescendo, decrescendo, and then followed by absence of the breathing follows. This phenomena can occur during wakefulness. What conditions you find these abnormal breathings? So these phenomena can occur during the wakefulness, when the individual is awake, or during deep sleep. For example, if you see children, young babies sleeping, you will be finding these patterns. They breathe in fast and at the same time they stop. So this particular central, even in adults also this is seen, that is the chain strokes breathing. And this is called central sleep apnea syndrome. This is called central sleep apnea syndrome. It is seen in voluntary hyperventilation and in high altitudes. Voluntary hyperventilation and in high altitudes. It may be caused by the damage to the respiratory centers or by the physiological abnormalities in congestive heart failure. So, when the heart is being having an abnormal condition like congestion, so that particular thing is called the congestive heart failure, and there also you find these things. So the respiratory damage could be because of many reasons. So the abnormalities of chain stroke breathing, maybe the pattern can be seen in the respiratory centers damage or because of congestive heart failure. And is also seen in the newborns, which I just said, immaturity of the respiratory system. So the neuronal setup is yet to get established. So there also you will be finding these things. And in normal human beings in deep sleep, probably in deep sleep when the REM sleep is going on, and then you are having the dream pattern, then also you find these abnormal patterns. And as I said, in abnormal conditions, the pathological conditions like brain damage and urine. And there is another type of breathing which is called Biot's breathing. So this diagrammatic representation I could not depict here. Biot's respiration is an abnormal pattern of breathing and is characterized by groups of regular deep inspirations followed by irregular periods of aspiration, apnea. The thing is, the respiration rises and then falls. And then there is apnea. So just like it rises up and then falls and then gap. And this is called the Biot's breathing. So in what conditions you find this abnormal pattern is the damage to the pons, and it may be because of stroke. So the stroke can be in the heart and stroke can be in the brain. When stroke in the sense is a vague term to say the obstruction to the blood flow, which can be in the heart, that is called heart stroke, which can be in the brain, which is called brain stroke. Or sometimes damage, that is trauma, that is injury. It could be road accident or any accident. And then there is a part of the brain which is called uncal herniation. And sometimes the Biot's breathing can be seen in meningitis, as I said yesterday. That is, meningitis is the inflammation of the dura, arachnoid, and piana. And sometimes that is also the medulla. So this may be asked in the examination. Highlight with your highlighter pen in your text so that you can concentrate and then read. And then just a note about the non-respiratory functions before we conclude. And I don't want to drag on for a longer time. So what are the other functions which the lung does besides filtration, besides the respiration, and then supplying oxygen and taking out carbon dioxide? Filtration of the microthrombi. Sometimes in the Viva, the session or in the short note question, they may just ask you about what are the non-respiratory functions of the lung, or sometimes non-excretory functions of the kidney. All these things you should also remember. So they function besides the main role which they are interested with. For example, the kidney is not just elaboration of or filtration of the urine, but also it elaborates erythropoietin precursor. And it also is responsible in one of the stages of vitamin D. All these things you should know. So here coming back to the non-respiratory functions of the lung. Filtration of microthrombi, that is the role in the coagulation of blood. Protease transport system, that is proteases and lysosomes and elastase are transported here. Alteration in the hormones. Some hormones, when they are transiting through the lungs, they are modified. That is, the renin-angiotensin is modified. So the alteration of the hormonal response, the renin-angiotensin aldosterone mechanism, converting enzymes are present. And in the lipid metabolism, the type 2 pneumocyantes are mainly responsible for the elaboration of the surfactant, which lines the alveoli and prevent the collapse. And that is mainly responsible for the functional residual capacity, which you just heard. And elimination of the respiratory metabolites, namely the acetone and anesthetic drugs. For example, you give anesthesia, and then these anesthetic drugs are eliminated through the respiratory system. Besides, the individuals who take alcohol, the alcohol is also eliminated through the respiratory thing. And besides, it stores about 10% of the blood volume. And it is also responsible for the elaboration of immunity, and it elaborates IgA. There are 5 different types of immunoglobulins: IgA, G, M, and E, and D. So all these immunoglobulins are elaborated. From among this, the lungs elaborate immunoglobulin A. And then this is another thing, which is emphysema. I don't want to elaborate because it is already 3:15. So this you can read from the textbooks. And then the pathogenesis you can just note down. The smoking causes the reduction in the elastase, and that in turn will result in alpha-1 antitrypsin deficiency, and that in turn will result in the destruction of the alveoli. So alveoli, what happens is the alveolar partitions are damaged, and then the total surface area is decreased because of the deficiency of alpha-1 antitrypsin. And then this becomes much bigger space. That is, the surface area is decreased because of the destruction of the partitions between the alveoli. And this is the paroxysmal nocturnal dyspnea. I think it is too much. It will take another 15 minutes for you to listen to all these things. Neha, I think I am stopping at this point of time.
Okay, sir. Thank you, sir.
Thank you, sir.
Read well, and then, as I said, you concentrate on the desktop, have the textbook on one side, a highlighter pen on the other side, and then a notebook. So whenever anything mentioned about the important question, you can highlight in the textbook so that when time comes, you can just concentrate on those topics. Or when it is dealt with in the theory classes, you can read about that. God bless you.
Thank you, sir.